Hello everyone, myself Saurabh Dodeja and this is Raj Patel. For today, our topic is malaria in pregnancy, guided by Svetlana ma'am.
Topic today. First of all, we will discuss introduction, then life cycle, then effects of malaria during pregnancy, labor, effect of malaria in the course of pregnancy, treatment, prevention and conclusion.
Malaria is caused by Plasmodium species. Vector for this is female Anopheles mosquito. It is endemic in Africa, Southeast Asia, Central America. It originated due to deforestation in Central Africa around 5,000 to 10,000 years ago. Yearly 2 to 2.5 million deaths occur, mostly pregnant women, infant 0 to 5 years old and HIV patient. 80,000. Malaria during pregnancy is a significant problem with substantial risk for the pregnant woman, her fetus and the newborn child. Life cycle of malarial parasite. First, the female Anopheles mosquito bites the human and transfers sporozoites in the human blood. Now these sporozoites transfer to the liver of human and there they infect hepatocytes and they form merozoites. Now these merozoites infect the red blood cell of human body and divide there. There they form two types of cells, that is merozoites and gametocytes. The merozoites cause the chill effects in the human body and the gametocytes remain in the venous blood. Now when the mosquito bites the human again, the gametocytes get transferred into the mosquito and the cycle goes on.
Effect of malaria during pregnancy, labor and puerperium. General pattern. General decline in immunity. Pregnancy may be interrupted. During pregnancy, frequency and severity of attack increase. Rapid installation of anemia. During labor, further stress occurs with tendency for clinical malaria to occur. Treatment must be via parental route. If clinical state is poor, the second stage must be use of either forceps or ventouse. During the puerperium, further stress occurs with increased tendency for subclinical malaria become clinical. Therefore, prevent relapse prophylaxis should be continued until 6 weeks postpartum. Lactation is not usually disturbed except in cases of severe pre-existing anemia.
Course of pregnancy. Pyrexia can induce uterine contractions, abortions, preterm labors, intrauterine growth retardations, intrauterine deaths, stillbirths. Placental parasitalization. The placenta acts as a spleen because of clogging of the intervillous spaces with macrophages, which is most marked during the second half of pregnancy. The extent of placental reaction is proportional to the severity of malarial infection during pregnancy. Treatment of MIP. WHO has given some criteria for drug combinations. Choosing combination must be effective. It must be able to delay the emergence of drug resistance. It should have high degree of compliance, must be cost effective, that is availability and accessibility.
Prevention. Remaining indoors between dusk and dawn, wearing long trousers and long sleeves, applying insect repellent to exposed skin, sleeping in a well-screened or air-conditioned room or under an insecticide-treated bed net.
Conclusion. Malaria is a complex parasitic disease that continues to be a global health challenge. Pregnant women are 10 times more susceptible to malaria and have greater risk of developing severe diseases with birth complications. Global efforts to prevent malaria are having some impact on public health and deaths due to malaria are decreasing in some regions of the world. This momentum must continue and must be sustained if we are to reach the target set for malarial control.
Thanks
for
your
everyone.
attention.